Picture the meeting where your health intervention was first designed. The donor was there. The technical experts were there. The implementing partner was there. Now ask yourself one question. Was the government office that will have to run this at scale long after the project ends in that room? For most health programs in Nigeria, the honest answer is no. They were invited later to a launch, a validation meeting, a handover ceremony. And that single absence, that gap between who designed the intervention and who must sustain it, is one of the biggest reasons good interventions stall the moment they try to scale. This is recommendation 1 of BWEIM, the ExpandNet and WHO set of 12 recommendations for designing interventions that are built to scale from the start. It says, engage in a genuinely participatory process from the very beginning, involving the key stakeholders. But here is the part most people miss. Not just any stakeholders. The people and institutions who will be responsible for delivering and sustaining the intervention at scale. In Nigeria, that almost always means government. And not government as a single block, but 3 levels of it. Federal, which sets policy and standards. State, which holds the health budget and runs the system. And local government, which manages the frontline facilities where care is actually delivered. If your design only speaks to one of those levels, you have engaged a fraction of the system you're asking to carry your work. Now, every project does stakeholder engagement. You invite people to a launch, you hold a validation meeting, you collect signatures on an attendance sheet. But that is consulting people about a design that is already finished. Recommendation 1 asks for something harder, co-design. The institution that will own this at scale should be a co-author of the design, shaping it, questioning it, committing to it before the first pilot site opens, not after the final report is written. Think about the difference in practice. In consultation, government reviews your work plan and offers a few comments. In co-design, government helps decide which problem you are solving, where you pilot, what success looks like, and how the work will be paid for when the project ends. One produces a polite endorsement, the other produces a stake. Consultation builds attendance. Co-design builds ownership. And only ownership survives the donor exit. We see this clearly in our own data. In our April 2026 scaling orientation in Abuja, 8 government entities, 6 states, and 2 federal institutions analyzed their own live programs against this framework. In 4 of the 8, government told us plainly that it had been excluded or sidelined from the original design, even though that same government is now expected to own and finance the scale-up. And the pattern went deeper. When these teams assessed their own readiness to scale, the weakest element, across almost every program, was the resource team, the mixed group meant to carry the work forward after the project closes. That is not a coincidence. When government is not a co-designer, there is no real team to hand over to. This is not a criticism of any partner or any donor. It is the legacy of how health programming has been done for decades. Designed quickly, piloted, handed over. But the result is predictable. When you inherit something you did not help build, you manage it like a guest, not like an owner. And the reverse is just as visible. Where government did help shape the design, we are already seeing the difference. One state has moved its scale-up plan into its own approved annual operating plan and primary healthcare budget. Government money, government ownership, before the project has even closed. That is what co-design buys you. and the launch invitation never will. So who actually needs to be in the room from day one? 5 groups. First, the future implementing agency, the specific government department or unit that will deliver this at scale, not the ministry in the abstract. Name the exact unit and put it in the room. Second, the policymakers who control budget and policy, because scale lives or dies on budget lines, and budget lines are political decisions, not technical ones. Third, the resource team, the mixed government and partner group that will carry the scale up after the project closes. If you cannot name who sits on it, it does not yet exist. Fourth, the frontline providers, the nurses, community health workers, and facility managers who will actually deliver the intervention under routine conditions, and who can tell you in 5 minutes what a work plan will get wrong in 5 months. And fifth, the community and its leaders, the people the intervention is for, whose trust decides whether it is used at all. Miss any one of these, and you have a predictable failure waiting, a design no unit owns, a model with no budget, a handover with no team, a workflow providers quietly reject, or a service the community never trusts enough to use. Doing this well is not complicated, but it is deliberate. Bring these stakeholders in at inception, when the design is still open, not at the validation meeting when it is already locked. Give them real decisions to make, not a presentation to applaud. Let government help choose the pilot sites, set the targets, and shape the budget. In practice, that can be as simple as this. At the very first design meeting, you do not arrive with a finished work plan to present. You bring the problem, and you let the government team help define it. You ask the implementing unit which sites are realistic. You ask the budget officer what the state could plausibly fund in 2 years. You write their answers into the design, and you write their names next to the commitments. By the end of that one session, the design is no longer only yours, it is theirs too. And build the ownership mechanisms early. A government chair for the project steering committee. An honest conversation about which costs the state will eventually absorb. And a written commitment, a memorandum, a budget line, a named officer. Not just a verbal nod across a workshop table. None of this slows you down. It front loads the conversations that skip now become the reasons your program cannot scale later. Let me give you a real example from my own work. On a private sector PMTCT and maternal health project on the Pathfinder's Evidence to Action program, we did not begin by rolling out training. We began by visiting the people who would actually deliver the service. The heads of the private facilities we hope to bring on board. And in those early conversations, before a single site was activated, they told us things that would have quietly wrecked the rollout if we had only discovered them later. They could not release more than 2 staff for a 6-day training. Several facilities needed structural upgrades before they could offer the service safely. One sat at the top of a road so steep that pregnant women struggled to reach it. None of that was in our original plan. We learned it only because we engaged the deliverers early and then redesigned around what they told us. We signed memoranda of understanding with each facility, and only then did we activate the sites. Engage, redesign, commit, then activate. That sequence is recommendation 1 in practice. Now, I know the objection because I hear it constantly. Government is too slow. Officers change with every election. They come to the workshop and then disappear. All of that is real. But notice what it actually tells you. If government is too disengaged to help design the pilot, it is almost certainly too disengaged to sustain it at scale. And you have just discovered your single biggest scaling risk on day one, while you can still do something about it, instead of on the day the project closes. So engagement is not a courtesy, it is a diagnostic. If the institution that must own this will not sit at the design table, that is not a reason to quietly proceed without them. It is the most important finding of your entire pilot. And the response is not to give up. It is to start smaller, invest in the relationship, and make winning that seat at the table the first real objective of the work. Recommendation 1 is the foundation, because every other design decision flows from who was in the room when it was made. Get the stakeholders right, and scale becomes possible. Get them wrong, and no amount of evidence will save the handover. That is why this is recommendation 1 and not recommendation 7. It comes first because it shapes everything that follows. In the next episode, we will look at recommendation 2, making sure an intervention is genuinely relevant and feasible in the setting where it has to scale. If this was useful, subscribe for the series. And tell me in the comments, at your last Inception meeting, who was missing from the room?